All right, let's just dive right in. Welcome to this explainer where we're taking a laser-focused look at alterations in hematologic function. But listen, we aren't just reading textbook definitions to you today. No way. We are breaking down the pathophysiology of hematologic disorders specifically to sharpen your clinical judgment. If you're prepping for the NCLEX, you already know the exam isn't just about knowing what a disease is, it's about knowing exactly what to do about it. It's all about priorities, safety alerts, and spotting those tricky test traps. So we're going to chunk this information, use some visual memory anchors, and master the tactics you need to safely care for these clients. Let's do this. To get us in the right mindset, picture this scenario. You're the nurse in the ER. You have a 47-year-old client who was just brought in from a motor vehicle collision, and they are vomiting blood. What would the nurse do first? When you see a clinical picture like this, your mind should immediately start screaming, hemorrhage and hypovolemic shock. Adults can tolerate about a 14% blood loss, but this is significant. Your client is at a massive risk for decreased cardiac output and altered mental status. So, how exactly do we prioritize our actions? Okay, here are your absolute, non-negotiable first moves. If the source of bleeding is external, your very first action is to don gloves and apply direct pressure. But think back to our MVC scenario. The client is vomiting blood. That means the bleeding is internal, so your priorities shift instantly to circulation. You need to ensure IV access immediately, and specifically, you need a large-bore IV catheter. Why? Because you're going to need to administer IV fluids rapidly as prescribed to keep that blood pressure up and literally fight off hypovolemic shock. And crucially, you've got to get a type-in cross-match done so you're totally ready to administer a blood transfusion. Keep these priorities locked in your mind. Now, before we look at how things break down in the body, let's quickly establish our baseline. It's like a giant puzzle, and we need to know the pieces. We have our normal blood components flowing beautifully here. You've got your erythrocytes, or red blood cells, and their job is carrying oxygen. You've got your granulocytes, which are your white blood cells, like basophils, eosinophils, and neutrophils, and these guys are your infection fighters. And then down at the bottom, you have your platelets, which are absolutely essential for clotting. Whenever a hematologic disorder pops up, always ask yourself, which of these three components is acting up, missing, or multiplying out of control? Section 1. The clots. Prioritizing perfusion. So what happens when platelets and clotting factors actually do their job a little too well, or they do it in the wrong place? We get an interruption in blood flow, which means a severe lack of perfusion. If we look at the cellular level, red blood cells and platelets start sticking together, gradually forming a plug that literally narrows the vessel. And clinically, this leads to your classic deep vein thrombosis, or DVT. This typically forms in the large veins of the lower extremities. But what causes it? Well, keep an eye out for the classic NCLEX culprits: immobility, especially after a surgery, and dehydration. As the nurse, your clinical radar should be scanning the lower extremity, particularly below the knee, for localized redness and swelling. Now, listen closely, because here is a major trap you need to avoid. Once a DVT is identified, the client is highly likely to be started on an anticoagulant, something like low molecular weight heparin. The huge safety alert here is that the treatment for the clot creates a brand new, potentially deadly risk: bleeding. So your priority completely shifts. You go from monitoring the clot to closely monitoring the client for signs of bleeding. You have to ensure they understand the side effects of their medication, and you must watch for worsening conditions like shortness of breath or chest pain. Why? Because that can mean the clot is broken off, traveled, and become a life-threatening pulmonary embolism. Section 2. The anemias, identifying the patterns. When you're tackling the anemias, the very best tactic is pattern recognition, based on the cause and the unique manifestations. Let's compare them directly. First up, iron deficiency anemia. This is actually the most common form worldwide. It's often caused by poor nutrition or blood loss. Without iron, your body just can't produce hemoglobin. These clients are going to present with fatigue, pallor, and shortness of breath. Your nursing education here heavily focuses on iron-rich foods and supplements like ferrous sulfate. Now, contrast that with vitamin B12 deficiency anemia. This is often caused by a vegan diet or malabsorption issues, like in pernicious anemia, where the body is missing intrinsic factor. Now, both types of anemia cause fatigue and pallor. But what is the distinct NCLEX pattern for B12? It's neuropathy, ataxia, and visual deficits. So the absolute crucial takeaway here is that a client with prolonged B12 deficiency isn't just feeling tired. They are a major safety and fall risk due to that neuropathy. Next up is an anemia with a completely different mechanism altogether: sickle cell anemia. This is an inherited disorder, and the absolute priority complication you must recognize is a vaso-occlusive crisis. This is an incredibly painful complication where sickled red blood cells essentially block blood flow to the tissues. When you see this on an exam or in practice, your immediate nursing interventions are twofold. pain control, and aggressive hydration. And you really want to visualize exactly why we need that hydration. Normal red blood cells are super flexible, right? They just slide effortlessly right through the blood vessels. But sickled cells, they are rigid, abnormal, and shaped kind of like a crescent moon. They literally get stuck at the branch points of the blood vessels, causing a massive traffic jam. This cuts off oxygen to the tissues, and that is what causes the severe, agonizing pain episodes that are typical in these clients. So we hydrate them to literally increase their blood volume, which helps flush and open up those vessels to restore that vital blood flow. Let's pause for a quick clinical judgment check. Imagine you're caring for a recently engaged client who has sickle cell anemia. She asks you if her future children could have the disease. How do you respond to that? Well, you need to recall the etiology. Sickle cell is a recessive disorder. This means that for a child to actually have the disease, both parents must carry the sickle cell trait. Your role here is to provide accurate education and likely refer them to genetic counseling resources so they have everything they need to make informed decisions. Section 3. Blood cancers, infection and pain. While the pathophysiology of blood cancer involves the bone marrow producing abnormal cells, your nursing priorities really boil down to managing extreme infection risk and pain. Let's take acute lymphoblastic leukemia, or ALL, for example. In ALL, the bone marrow basically goes into overdrive, making way more lymphocytes than needed. But here's the catch: these aren't healthy cells. The end result is that the healthy white blood cells, red blood cells, and platelets are completely outnumbered. So what is the major safety consideration? Well, because their healthy infection-fighting white blood cells are severely depleted, they are at an extreme risk of infection. Your client education absolutely must emphasize minimizing time in public places. And because their platelets are also outnumbered, you've got to be hypervigilant in watching for them bruising easily or any bleeding risks. Let's look at another classic leukemia pattern: chronic myelogenous leukemia, or CML. CML is characterized by a very specific genetic mutation called the Philadelphia chromosome. What happens is a piece of chromosome 9 actually swaps places with a piece of chromosome 22. Want a great memory trick for this? Just think Philly cheesesteak. The C and M in cheese and meat can remind you of CML. It's a bit silly, but it works. If you see the words Philadelphia chromosome, immediately link it to CML. All right, before we wrap up, we have to talk about a really high-stakes ethical and legal trap. Let's say you have that hypovolemic MVC client with massive blood loss. The medical indication is crystal clear. They need a blood transfusion to survive. But the client is a Jehovah's Witness and explicitly refuses the blood. What is your priority? As a nurse, you absolutely must recognize that a competent adult has the legal and ethical right to refuse medical treatment, even if it is life-saving. Your role is not to argue with them. Your role is to provide support, ensure the client fully understands the risks of their refusal, and immediately tap into your interdisciplinary resources, like the provider and the hospital ethics committee, to explore alternative fluid volume replacements that align with the client's beliefs. Section 4. Rapid recap and review. Okay, we have covered a ton of ground today. Let's ramp up the energy and do a rapid-fire recap of the absolute deadliest complications and your priority nursing actions. This is the stuff that literally saves lives on the floor and gets you those passing points on the exam. Here is your cheat sheet. Lock this table into your brain. Hemorrhage. The greatest risk is hypovolemic shock. Your first action is to apply direct pressure if it's external and get a large bore IV for fluids if it's internal. DVT. Remember, the trap isn't just the clot, it's the bleeding risk from the anticoagulant medications used to treat it. Monitor them closely. Sickle cell anemia. The massive threat there is a vaso-occlusive crisis. Your immediate priority is hydration to open up those vessels and pain control. And finally, ALL, or acute lymphoblastic leukemia. Because healthy cells are totally outnumbered, the greatest risk is a severe infection. Your primary safety instruction is to minimize their public exposure. So, I want to leave you with a final thought to mull over. Describe 3 ways your clinical judgment improved regarding hematologic disorders today. Take a moment to actually answer that for yourself. Did you master the difference between an iron deficiency and a B12 fall risk? Did you lock in the priority of hydrating a sickle cell crisis? Because when you shift from just memorizing facts from a textbook to actively anticipating the priority risks, you aren't just learning anymore. You're thinking like a nurse. Thank you so much for joining me for this explainer. Keep applying that sharp clinical judgment, and I'll see you next time.